Good afternoon. I would like to thank the organizers for the privilege of presenting at this meeting. Today, I will be talking about compartment syndrome. I have no disclosures. My first case is a 70-year-old male with hypertension, diabetes, coronary artery disease who presented with right foot rest pain. On exam, he had palpable femoral pulses and non-palpable distal pulses bilaterally. His ABI on the right was 0.54 with a toe pressure of 38 millimeters of mercury. He underwent an angiogram of the right leg. This showed an occluded right SFA and a diseased tibioperineal trunk. The SFA was crossed and stented, and the TP trunk lesion was angioplasty. Completion angiogram, however, showed perforation of a branch of the PT. This was then embolized. However, the patient was complaining of severe right calf pain and his leg was tense at the end of the case. A compartment syndrome was therefore suspected and he was taken to the operating room for a 4-compartment lower leg fasciotomy. This case highlights the importance of recognizing perforations during an angiogram and being aware of the risk of compartment syndrome with this complication. It also highlights the need to perform a completion angiogram on all cases. My second case is a 68-year-old male who has history of hypertension, hyperlipidemia, and who developed acute onset of right leg pain at rest. He complained of tingling and numbness of the right leg. On exam, the patient had palpable bilateral femoral pulses and left DP and PT pulses. However, the right DP and PT signals were absent. He had decreased sensation in the right foot and a normal motor exam. His ABI on the right was 0 and a toe pressure of 0, and on the left side he had normal ABIs. Workup revealed a thrombosed popliteal aneurysm on the CT scan. He underwent an angiogram which revealed the thrombosed popliteal artery and 2-vessel runoff via the PT and perineal artery. The thrombosed popliteal artery was crossed and thrombolysis was initiated with TPA. He was then transferred to the ICU. After 20 hours, he went back to the operating room. The popliteal artery was now patent with some residual thrombus. This was excluded with a Y-bond stent. He had a palpable PT at the end of the case and 2-vessel runoff on the completion angiogram. 5 hours after the procedure, however, the patient had severe pain in the leg that was worse than when he came into the hospital. On exam, his right leg was tense, painful to passive ankle movement. He had decreased sensation in the right foot. We went to the operating room emergently for a 4-compartment fasciotomy. This case highlights the importance of being aware of ischemia reperfusion syndrome in the setting of acute limb ischemia, and that we should be vigilant for the development of compartment syndrome. Compartment syndrome is caused by an increase in tissue pressure within an enclosed anatomic space that exceeds the perfusion pressure of the tissue and jeopardizes tissue function and viability. The clinical features include painful swelling of the affected region, followed by loss of sensory and motor function. Irreversible muscle and nerve injury may develop unless this is promptly diagnosed and treated. This figure shows the pathophysiology of extremity compartment syndrome, which is initiated by an increase in the compartment volume, which could be because of bleeding, as in our case. This leads to an increase in the compartment pressure, which in turn leads to a decrease in the perfusion, tissue perfusion. This causes edema, which in turn increases the compartment pressure and leads to a vicious cycle that ultimately causes tissue death. The 5 P's of the syndrome to look for on clinical exam are pain, paresthesia, pallor, paralysis, and pulselessness. Of Of these, only pain and swelling are early signs, while the rest are late signs and may indicate irreversible muscle and nerve damage. Compartment syndrome is a clinical diagnosis, but there may be situations when it may be necessary to measure compartment pressures. This can be done with a commercially available device, an example of which is the Stryker needle shown in this picture. The needle is inserted 1 to 3 centimeters into various muscle compartments, and after injecting saline in the tissue, the dial shows the compartment pressure. A pressure more than 30 millimeters of mercury is considered significantly elevated. This syndrome requires immediate attention, and treatment is surgical decompression of all the compartments of the extremity involved. This slide shows pictures of thigh and lower leg fasciotomies. It is important to ensure that the muscles are completely decompressed, otherwise further tissue necrosis can occur. These incisions are commonly left open to allow the muscles to bulge through the incision. If leg and muscle edema improve over time, the incisions can be primarily closed. If this is not possible, the patient may require a skin graft in the future to facilitate wound healing. Thank you for your time.